So Sharmila, perhaps we can start. I will introduce you now. Hi, everyone. Thank you for joining today's session on AGP, ABCs of AGP. I would like to introduce Professor Sharmila Sengupta, who is a veteran in IPC. I've learned lots of IPC from her, and I think she's probably the best person I can think of to chair this session. And she's currently working as an associate professor in microbiology and IPC in New Delhi, India. And I will hand over the session to Professor Sharmila to continue from there as a chair. Thank you, Sharmila.
Thank you, Kalis. I think, definitely Kalis has overestimated me, but I'm very happy, and it's a pleasure and an honor to be here in this IPC club, and especially to have Andrew, Professor Andrew Stewardson as our speaker. I think aerosol generating procedures are something very important, and it has become much more important with the pandemic in place. And it seems that we really were kind of stuck to a few things which we thought were aerosol generating procedures. But now with the pandemic and all the research which has happened and outcome, we have found out that there are much more to know about aerosol generating procedures than what we knew. So I would like to introduce Andrew, who is an infectious disease physician and an associate professor at the Department of Infectious Disease, the Alfred and Central Clinical School of Monash University in Melbourne, Australia. His research has focused on the health and economic impact of antimicrobial resistance and healthcare-associated infections, the transmission dynamics of antimicrobial resistance, and the implementation of infection prevention and control. So I think we have, no better person than Andrew to tell us about aerosol generating procedures, ABCs of AGP. Thank you, Andrew. You can start.
Thank you, Sharmila. Thanks for the invitation, for the introduction. It's lovely to see you again, and thanks to Carlos for the invitation. It's nice to be part of this great new club. So I'm just trying to share my slides. Okay, so I'm hoping that that's in full screen mode, and please sing out Sharmila if it's not. Yeah, nice to be with you today. Thanks for the opportunity to have a chat. Just a bit of background. I'm based in Melbourne, where the red dot is down in the bottom of Australia, the bottom corner of Australia, and at the Alfred Hospital, which is pictured there. We're about a 600-bed hospital, and with regard to COVID and aerosol generating procedures, anyway, we've got a cystic fibrosis unit, heart and lung transplants, we've got the statewide HIV service and a large ECMO service as well. So just to start off with, I thought I would just, acknowledge the fact that aerosol generating procedures have been subject to quite a lot of discussion and some controversy, at least in Australia, and I'm pretty sure in other countries as well during the last couple of years, and the subject of some challenging discussions. So we'll try and keep this gentle. This is a Gordian knot, so just to recognise the fact that aerosol generating procedures are sometimes in the centre of some challenging problems that are difficult to solve. And I'm not suggesting at all that this presentation, I'm afraid, is going to solve any of the problems around aerosol generating procedures or give you definitive answers, but I hoped that there would be something to gain from having a bit of discussion and sharing our experiences and reviewing some of the recent evidence and thinking about a way forward. So yeah, despite Sharmila's kind introduction, I don't have a particular research background in aerosol generating procedures, but more just kind of keen to have a bit of a think about them and how to incorporate them into infection prevention going forwards after our experience over the last couple of years. So what I'll do is just to give a very brief context and provide some rationale. I'm going to do a case study. There's too much to cover, obviously, to think about all aerosol generating procedures, but I thought I would just start with nebulizer therapy because it's treated differently in different countries, and also because we have particular issues with it here in Melbourne. I'll review briefly some evidence from some other common aerosol generating procedures, and then finish up with some concluding thoughts before very much looking forward to the input, comments and questions from everyone else. All right, so I suppose we need to start with a definition of aerosol generating procedures. And this one I've taken from the NHS in England, which is pretty similar to the WHO definition, but they say that aerosol generating procedures are medical procedures that can result in release of aerosols from the respiratory tract, and that criteria for an aerosol generating procedure are a high risk of aerosol generation and increased risk of transmission when the patient in question has known or suspected respiratory infection. So I suppose there are two components there to emphasize, and this will, I think, be relevant later on. One is the generation of aerosols, but the other is that there must be an increased risk of transmission associated with those aerosols. So that's the definition, but of course the next question always in our policies is what is the list of aerosol generating procedures? What are these procedures that we're talking about? And again, just for the moment to stay with the National Health Service in England, in the UK, this is their current list based on a recent review of the evidence in June 2022. So that their list at the moment is awake bronchoscopy, awake ENT, airway procedures, and so on down the list you can see there. But you know, one of the initial problems that comes up talking about aerosol generating procedures is the fact that we've all got slightly different lists. So I've tried to compare here what I think are the most recent lists from World Health Organization, the UK, NHS, and US CDC. You can see highlighted in grey some areas, some procedures that are listed by some and not by others. There are certainly some overlap, but it's by no means the majority that is overlap between all three. And I suppose up the top there's some interesting that NHS doesn't include non-invasive ventilation and tracheal intubation, which I think traditionally have been sort of amongst the most high-profile aerosol generating procedures. And we'll talk a little bit more about why that is later on. But yeah, I suppose just to highlight the first problem when it comes to aerosol generating procedures being the fact that we don't have a definitive list, and it's quite difficult to establish that. And in fact, these documents, to be fair to them, all explicitly state, I think, the fact that it is difficult to develop a definitive list, and there needs to be some degree of risk stratification by healthcare workers when they're thinking about this. So, and just the last part of a brief introduction is to state the obvious. I suppose, you know, prior to COVID, I think most guidelines would say that if you're managing a patient in what we've typically thought of as droplet precautions, if that patient's having aerosol generating procedures, then we then need to use airborne precautions, which amongst other things involves an N95 and airborne infection isolation rooms. But what we've had during the pandemic is, I think, pressure placed on this concept of an aerosol generating procedure from all sorts of directions. And I guess I'll try and expand on that a little bit throughout this presentation. But that might be pressure from various colleagues who come to us in infection prevention with new procedures that they would consider to be at risk of transmission of COVID, perhaps from societies in our countries that have released position statements saying that particular procedures that we hadn't thought of previously are aerosol generating procedures. And then just the challenges around identifying which patients will be having these aerosol generating procedures and how can we best place them given the numbers of patients that we've been looking after during the pandemic. So I suspect that we've all felt this pressure on the concept of aerosol generating procedures over the last couple of years. So just to bring it back to a case, and this case actually came up I think soon after, a day or two after Carlos and I first discussed this potential topic from memory, which is, I thought was timely and why I included it. It's always good to come back to a case, isn't it? So this is an 87-year-old woman who was admitted to hospital with a fall. She had a new lung mass identified, and she had pneumonia on the background of chronic obstructive pulmonary disease. She was admitted to one of our wards, our rehabilitation wards, on the 27th of June to a single room with a dedicated ensuite. She is non-ambulant, but she had regular visits from her daughter. Sometime later, on the 8th of July, she had a new oxygen requirement and rising inflammatory markers. She tested negative for COVID, but then 4 days later tested positive. And throughout this whole time, she'd been having nebulizer therapy 4 times a day with the door open. So the question is, should the nebulizer therapy change our outbreak response in this particular case? This particular ward is not known for having particularly great air handling. So why might nebulizer therapy increase transmission risk? And this goes back to the rationale that we have to ask about all aerosol generating procedures. And the reasons that are given in the literature are, firstly, airflow across moist mucous membranes, which can lead to virus-contaminated aerosols. I think this is pretty universal amongst most aerosol generating procedures, this concept of airflow across moist mucous membranes, and the fact that the velocity of the airflow, the higher it is, the higher risk the procedure might be. And there's also the fact that nebulizer therapy might induce coughing, the fact that increased humidity associated with nebulizer therapy might alter particle dynamics and virus viability. And quite apart from all of those physical things, the fact that a patient on nebulizer therapy might actually need more regular care. In fact, it's just a marker of the need for healthcare workers to be in close proximity frequently for prolonged periods of time to the patient's respiratory tract, regardless of whether or not the nebulizer therapy increases aerosol production. So the question is whether this is an aerosol generating procedure. So this is a schematic representation of an infection control team member's brain and things that might impact on a decision about the risk associated with this situation include anecdotes, our own sort of experience, guidelines that are available to us, and evidence if we have time to go and look at it. So I thought I'd start off with just a couple of quick anecdotes that had occurred here locally prior to this particular case that I gave. And then the second anecdote was associated with our hotel quarantine program in Melbourne. We had an outbreak of 24 cases at the Holiday Inn Airport Hotel, including transmission from residents to staff and also to other residents in separate rooms in this hotel. One of those staff members may have acquired infection from direct contact, but the others were a bit unexplained, and there was a review that suggested that an incident with a nebulizer was investigated as a likely source of infection for 6 other cases. We don't have much more information other than that. So two anecdotes that sort of were a little bit of a warning for us. Yeah, then we look at guidelines. This is our own internal hospital guideline, which says that, yeah, as already covered, aerosol generating procedures in someone in droplet precautions, which at the time, essentially right back at the start of the pandemic is what we had our patients in, means that we then need to manage them according to airborne precautions for the duration of the procedure at very least. And our list internally of aerosol generating procedures included nebulization and still does. Just to clarify a little bit further, really in our guideline, and I think this is consistent with a lot of practice prior to the pandemic and in non-pandemic times, if you had a patient with suspected or confirmed respiratory illness, then you would defer the aerosol generating procedure if you could, otherwise place them in an in-class room if possible, or a single room, and use tier 3 PPE. for all other patients, we continue to manage in standard precautions. So that was our hospital guideline. At the Department of Health locally level, there was similar guidance. And again, the statement that nebulizers are considered to be aerosol generating procedures, and that also included CPAP and BiPAP therapy. And the statement went on to say that that even COVID-free patients, patients who aren't suspected or confirmed to have COVID, aerosol generating procedures, including nebulization, should be performed in a single room with the door closed, although this has subsequently been removed. We also have a national statement in Australia, which is from our Australian Commission on Safety and Quality in Healthcare, which was drafted in collaboration with the other organisations listed there, which states that we should avoid nebulization where possible in adults during the pandemic, and that the use of nebulizers carries high risk to staff and patients of viral aerosol infection. Nebulization induces coughing, and this may contribute to virus spreading. And they talk about, in the second paragraph there, the risk of infection transmission by aerosols may increase during nebulization due to the potential to generate high volume of respiratory aerosols, which may be propelled over a long distance than occurs with natural dispersion. So that underlined section links to evidence underlying that particular statement, and I'll come back to that a little bit later on. So that's in Australia. US CDC says that there's it's uncertain based on current evidence whether nebulization is associated with risk of aerosols. The NHS at the time says that nebulization is not an aerosol generating procedure, and the WHO again has some uncertainty around nebulizer therapy. This, I think, was an interesting study which looked at official guidance and academic publications and how they define and classify aerosol generating procedures. And I think the overall gist of this paper was that there is quite a lot of diversity and heterogeneity in the way that aerosol generating procedures are defined in various documents, and also the specific procedures that are listed. But it did, however, just with regard to this particular example, state that nebulized therapy was in the top 10 of procedure groups classified as aerosol generating when this review was done in 2020. And I can see there's already a really great question, which we'll come back to later on in the Q&A. Thanks very much. Yeah, please feel free throughout the whole thing to pop questions or comments in the Q&A or the chat. So that I've talked about anecdotes, guidelines, and so now evidence. And I said that I would come back to this national statement from Australia to review the evidence that was linked to there. So the paper that was linked to is this particular one, which is a letter, and it talks about the fact that one of the just to note that one of the contributors to this letter is employed by a company that sells this device, which is a chamber used for nebulizer therapy, and so. The comment here is that because of the potential to generate high volume of respiratory aerosols that may be propelled over a longer distance than might be involved in natural dispersion pattern, that's why nebulizer therapy is a serious problem. So if you then follow that reference to reference 1, you end up with this review, which doesn't have a lot of information about nebulizer therapy, but what it does have is to link to this paper, which is a really interesting paper from 1980, but it's not really about the problem that we're looking at with regard to having nebulizer therapy for a patient who's infectious. It's about the actual nebulizer itself being contaminated. So that wasn't particularly sort of relevant to the issue at hand. So what I did was to go back and just have a little bit of a look at evidence around nebulizer therapy, and there's quite a few really interesting papers, as you can imagine, that have come out over the last few years. So this particular paper just shows the pattern of droplet production during nebulizer therapy and also during a cough, and it did show that with nebulizer therapy there are fine droplets that were observed floating and filling the space inside this chamber that was made for the purposes of this experiment, similarly to coughing. This paper was interesting. So it looks at the total concentration of aerosols and also the aerosol size distribution following various different procedures. So you can see here, this is total concentration of aerosols. We've got things like talking, breathing, a wet cough, a face mask, etc., etc. And the BiPAP over here, the procedure with the most aerosols by quite a fair way, given this is a logarithmic axis here, is a face mask with a nebulizer. So the conclusion here was that for the first time, to our knowledge, we evaluated aerosol generation associated with common respiratory therapies in a clean room. This was a clean room. And we found that non-invasive ventilation and nebulizer therapy were significant aerosol generating procedures. But I think important to remember back to the definition at the start, which talked about aerosols, but also the risk of transmission, which obviously itself is not here. In fact, all we know is that these are aerosols, not that the aerosols contain virus. Also interesting to look at this study, which I won't talk about in detail, but which just compared different types of nebulizers and the fact that the choice of nebulizer device itself impacts on the potential for patient-derived bioaerosol release. So I guess suggesting that we can't just talk about nebulizers, that we need to talk about particular types of nebulizers. And then this paper, going back in time to the SARS period, which looked at a single patient with SARS in an N-class room who was being treated with a large volume nebulizer, and they took air samples and found that that there wasn't any positive PCR results suggesting aerosolization of SARS in this particular paper. And then finally, moving to that last stage of the risk of actual infection and epidemiological data. So this interesting paper was from the Prince of Wales Hospital in Hong Kong in 2002. They talked about their first SARS patient. This was the only inpatient with SARS in this hospital from the 4th to the 10th of March, and the patient was bedbound. They described a super spreading event where SARS was transmitted to 47 healthcare workers on this patient's ward. This included 15 of 16 nurses, 6 of 6 doctors, and 16 of 66 students. And it was attributed to a jet nebulizer leading to aerosolization as being the cause of the super spreader event. So this paper reported a case control study looking particularly at those 66 students to look at risk factors amongst those students for infection. And what they found was that infection was actually most clearly associated with proximity within 1 meter from the patient, with a relative risk of 7.4 rather than the nebulizer therapy itself. And interestingly, they noted that efficient transmission occurred prior to nebulizer therapy. So there were lots of healthcare workers and students being infected prior from the 4th to the 6th of March, which is before the nebulizer therapy was started. But their conclusion was that because nebulizer therapy could theoretically exacerbate symptoms of coughing in SARS patients, that they recommended avoiding the use of nebulized medications and other potential aerosol generating patient care procedures if possible, or use appropriate infection prevention precautions. Then probably I think most people will be familiar with this paper from 2012, which is a systematic review of transmission associated with aerosol generating procedures, particularly around SARS transmission. And they looked at many procedures, which I'll get back to in a moment, but in particular for nebulizer treatment, they found 3 cohort studies. And the pooled odds ratio for transmission for healthcare workers exposed to nebulizer treatment compared to those who were not. The odds ratio was 0.9, but with very wide confidence intervals, so indicating high uncertainty, and also with those 3 cohort studies, an I-squared value indicating high heterogeneity. So I guess low quality evidence. So that was my little sort of detour down nebulizer therapy, and I suppose I was hoping that might be kind of a model for thinking about other aerosol generating procedures as well, and at least the thought process that I was having of thinking about initially sort of anecdotal experience, but then also what do the guidelines tell us, and what evidence informs those guidelines. What I thought I might do now, as I said at the start, is just to go through some more recent evidence for other procedures before wrapping up. So back to that systematic review from 2012, there were 4 procedures that they found from that systematic review to be associated with an increased risk of transmission, those included tracheal intubation, with 4 cohort studies and 6 case control studies finding the same odds ratio. And again, this is comparing healthcare workers exposed to these compared to those who were not. So odds ratio of 6.6, pretty high. Non-invasive ventilation, 2 cohort studies with an odds ratio of 3. Tracheotomy, 1 case control with an odds ratio of 4. And manual ventilation before intubation, odds ratio of 2.8. Procedures where increased risk was not detected, not that this is evidence that they're absolutely not aerosol generating procedures, but they didn't detect a signal, included many others that you can see listed there, including endotracheal aspiration, suction of body fluids, bronchoscopy, nebulizer therapy, administration of high flow oxygen, manipulation of BiPAP mask, chest compressions, and so on. There's some recent interesting evidence, so I'll just go through relatively briefly. So this paper had the question, posed the question, do high flow nasal oxygen and CPAP produce clinically relevant aerosols? So they had healthy volunteers breathe, speak, and cough, and also use CPAP and high flow nasal oxygen, and aerosol emission was measured. And the conclusion there, if you look at the graph just briefly, you can see these are patients, these are during the breathing, speaking, and coughing periods. Here, circled in red, I've got the, think about CPAP for the time being, another procedure that came up quite a lot for discussion in our hospital over the last couple of years. Actually, breathing with CPAP or breathing with a leaking CPAP, you can see that the particle concentration was actually lower than just breathing. And similarly, speaking with CPAP, a lower particle concentration than just speaking or speaking with a fluid-resistant surgical mask. Similarly, with coughing, you can see here just coughing alone, perhaps slightly lower particle concentration for coughing with a CPAP or coughing with a CPAP that's leaking. And the conclusion here was that in healthy volunteers, CPAP produced no aerosols. And I didn't point out the high flow nasal oxygen, but the comment here was that the high flow nasal oxygen produced no clinically relevant aerosols, while coughing was associated with significant aerosol production. So suggesting here that actually coughing is a higher risk, well, it's not a procedure, but higher risk event than using a CPAP or high flow nasal oxygen. This is another paper. Research question here is, do hospitalized patients with COVID-19 receiving treatment with continuous positive airways pressure or high flow nasal oxygen present a significant added risk of viral contamination? So we're not just talking about aerosol generation, but actual viral contamination. And here they looked at 30 hospitalized patients with COVID-19 who required supplemental oxygen. And those patients received either supplemental oxygen, CPAP, or high flow nasal oxygen, 10 per group. And they took samples from each participant, a nasopharyngeal swab, 3 air samples, and 3 surface samples, and performed PCR and viral culture. Overall, so just in terms of context, this was performed at the end of 2020, start of 2021. when B117 was the dominant variant, and they found in terms of PCR results that 70% of nasopharyngeal PCRs were positive, whereas only a very small number. There were 3 samples of air and surface per 30 participants, so there were only 40 positive air samples and 6 positive surface samples by PCR, and neither CPAP nor high-flow nasal oxygen use or coughing was associated with more environmental contamination than supplemental oxygen use alone. And only 1 sample was culture positive, and that was a nasopharyngeal nasopharyngeal sample. And so their conclusion was that CPAP and high-flow nasal oxygen may not increase risk above supplemental oxygen use. Here's a preprint, so just to emphasize that this hasn't gone through peer review yet, but a preprint which compared the prevalence of aerosolized SARS-CoV-2 virus in rooms of COVID-19 patients who were requiring AGPs, and compared to those requiring supplemental oxygen and those on room air, and 60 to 70 patients in each group. So samples were collected prospectively near to adults hospitalized with COVID-19 at 2 hospitals in the UK in the period provided there, for about a 12-month period. And you can see the sampler that was used in this particular study. Here we can see, if you look first on the left, there's the percentage of samples that are PCR positive. We've got amongst the aerosol generating procedure patients with aerosol generating procedures, about 20% or so, those on supplemental oxygen, 30%, and those on room air, a bit above 20% PCR positive. And there's no significant difference statistically between those groups. And then the table on the right sort of builds on this by looking at cycle threshold values of the positive PCR. So amongst those samples that were positive, what was the cycle threshold value? We've got the 3 gene targets here. And within each gene target, there's aerosol generating procedures, oxygen, and room air. Again, no statistically significant difference within each gene between the 3 groups of patients. So the conclusion of this preprint was that SARS-CoV-2 viral RNA was detected in the rooms in the air of hospital patients of COVID-19 patients, and that aerosol generating procedures did not appear to impact on the likelihood of viral RNA. Enhanced respiratory protection and appropriate infection prevention and control measures are required to be fully and carefully implemented for all COVID-19 patients to reduce the risk of aerosol transmission. And then finally, I think this is the last paper just to briefly go through, if I remember correctly, this paper looking at the effect of respiratory activity, non-invasive respiratory support and face masks on aerosol generation and its relevance to COVID-19. So their aim here was to measure the size, total number and volume of human aerosols from 10 healthy subjects. They compared findings in the 10 healthy subjects with and without face masks. And so the respiratory activities that they did were quiet breathing, talking, shouting, forced expiratory maneuvers, exercise and coughing. And the 3 respiratory therapies were high flow nasal oxygen, non-invasive positive pressure ventilation, 2 different types of non-invasive positive pressure ventilation, single or dual circuit. And this is below a schematic to show the setup that they used to do this experiment. And so here's the finding. Again, I'm jumping a little bit around here between papers that looked just at aerosols and those that looked at aerosols with some sort of marker of virus being present, be it PCR or culture. But here's the finding here that, again, we've got number of particles here on a log scale. These are the findings after the respiratory activities, and these the number of particles during the respiratory therapies at maximal setting. So high flow nasal oxygen and non-invasive ventilation. And so we've got breathing, talking, exercise, shouting, and so on, and up to coughing at the very top here. So suggesting that, in fact, similar to a previous article that I showed, if you think about breathing and talking as being relatively normal activities, the respiratory therapies actually were similar, if not slightly lower, in terms of numbers of particles generating, whereas the increase in particle generation was really with the other things like coughing and shouting, exercising, and so on. And so, yeah, the conclusion here was that respiratory activities, which mimic respiratory patterns during, which, you know, they claim mimic respiratory patterns during illness, generate substantially more aerosols than non-invasive respiratory therapies, which can in fact reduce total emissions. And I suppose this is in some ways similar to the quite well-known example early on of super spreading event associated with choir practice in the US in March 2020, and locally, and I think, you know, a lot of people started to talk about the concept of aerosol generating behavior rather than aerosol generating procedures. And this locally to us in Melbourne was driven home by a report and experience from the Royal Melbourne Hospital, another hospital here in Melbourne, which had at the time the largest outbreak involving healthcare workers, unfortunately, of 262 cases. And what they found was that anecdotally, staff noted that particular behaviour in infected patients appeared to be linked to transmission events, in particular shouting and vigorous coughing. And this was largely amongst, I think, a cohort of patients who were from residential aged care facilities who also had dementia and cognitive impairment and some degree of shouting associated with that. So back to this table, which looks at differences between guidelines in different countries. And in particular, I highlighted before the fact that the UK no longer includes tracheal intubation or non-invasive ventilation in their list of aerosol generating procedures. And that was because of this review that was done not all that long ago, actually, just updated in June of this year, which for tracheal intubation and extubation reviewed 3 studies, and for non-invasive ventilation, 7 studies, including several of those that I presented earlier on. In both cases, they said that the evidence identified suggested that it may be appropriate to remove those procedures from the list of aerosol generating procedures, which is what subsequently happened. So just a few closing thoughts before really looking forward to hearing what everyone else thinks. Aerosol generating procedures, I think in theory, you know, we always like a risk-based approach, or often do in infection prevention, and this does seem appropriate to identify risk associated with particular procedures. But I think there are a couple of challenges. The first is that it's very hard to define what is an aerosol generating procedure. And we faced that a lot over the last couple of years. There's not a lot of evidence, and most of what evidence that we have is not high quality, although there is increasing evidence over the last year or so. And it's also, in addition to just being hard to define which procedures are aerosol generating, it's also challenging to implement in practice. I think we all know that, or I imagine it's a common experience that it's easier to implement horizontal strategies that apply to all patients rather than having to pick specific patients and know which ones and apply a particular procedure to that particular sort of patient in a vertical sort of way. So yeah, an implementation problem in addition to the difficulty in defining aerosol generating procedures. I think that during the current pandemic, my perception, and I'd be interested to hear what others think, is that our idea about the baseline risk for all patients, including things such as coughing, which are obviously pretty common in patients with viral respiratory infections, is higher than previously appreciated, and that at least for some aerosol generating procedures, the risk may potentially be overemphasized. And so I guess just as a finishing point, I think in a lot of places, this has prompted a bit of a review of transmission-based precautions. or ideas around our traditional frameworks, including the concept of droplet versus airborne precaution. Certainly, we've needed to decouple the concept of an N95 and needing to place the patient in an in-class room. We've used N95s more widely than we ever have before. And there are certainly, I think, some suggesting that the concept of an aerosol generating procedure, maybe the importance of it, or the utility of it, is lower than we might have thought previously, given it doesn't capture risk sufficiently. So a few thoughts there, and rather than, as I warned you that I'm afraid I wouldn't have answers that I would be giving you or definitive statements, but I wanted to end on a few questions, and I'd be really interested to hear what others think. So do you think that the concept of an aerosol generating procedure, sorry for the spelling there, is a useful way of stratifying transmission risk in patients in healthcare settings? Has your opinion about the risk associated with aerosol generating procedures changed during the pandemic? And how will you incorporate aerosol generating procedures into your facility's infection prevention policy over the next couple of years? So with that, I'll stop, and I'm interested to discuss further.
Thank you, Andrew. It was a very, enlightening presentation, especially when there is a huge gap in understanding of aerosol generating procedures. And I would just want to wrap up, for today's session by saying thank you so much, Andrew, for your very interesting and enlightening talk, and Kalis for giving us this opportunity to have this good discussion. I hope there will be a lot of thoughts coming in the minds of participants on how and where and how to mitigate, to perceive the risk of transmission and mitigate transmission. And there would be more research in this area, and what kind of resources which we should utilize appropriately and not waste whatever we have.
Yeah.
Thanks, Kalis, for this. And
yeah.
I think we should wrap up now with your words.
With my next publicity for the next talk, right? But before that, I would like to thank Andrew for taking on this very difficult topic. I think I shy away from this particular topic, reviewing it, because it's just so riddled with lots of controversy. So thanks for doing it. And thanks, Sharmila, for sharing it, and Miaoling for coming on as a panelist. It was a very interesting talk. And thanks to all the participants, and obviously for the interesting questions. Just unfortunate that this session has to end, and it's already past the time. So just a quick plug-in for the next session, 8 November, same time. It's by Dr. Associate Professor Ng Moon from Singapore, NCID, Singapore, on whole genome sequencing, the good for IPC, the good, the bad, and the costly. So we have Prof Andrew Stewardson from Thailand as a panelist, and Dr. Maxine Bloomfield from New Zealand as a panelist as well. Prof Andrew Stewardson, all of you know, is an IPC person, and she's done lots of work in IPC. And Dr. Maxime is a microbiologist with lots of interest in whole genome sequencing from New Zealand. And I'll be chairing the session. So looking forward to seeing you all for the last session of the year on 8 November 2022. Thank you.